Thank you all. I know you've had a super long day. I'm not going to keep you with a lot of stuff that you've gone through. My job here today is to hopefully give you a bit of a recap of what you covered, share, I think, some perspectives about what organizations can do, and certainly build on the wonderful presentations of today. It's a real honor and pleasure to be here, and really appreciate the kind invitation to be part of this partnership stakeholder meeting. Certainly there's no doubt that I want to commend you all so much for tackling this issue at the state level. This is something that's very, very pressing nationally, and I get a chance to bounce around a bit, and certainly I think this is a very, very impressive effort, so I really commend you and wish you all the best of luck. This work is especially important in the time of the incredible healthcare transformation that we're involved in, where we finally feel like our focus on value and quality and safety are connecting very, very well with issues of communication. Whether it be efforts to prevent readmissions, whether it be efforts to improve decrease avoidable hospitalizations, improve patient experience, prevent medical errors, and improve patient safety. Finally, I think our healthcare system has realized that communication, not rocket science, is absolutely essential, and it's getting the due that it needs. I will say, though, that part of the challenge is we could have a lot of goodwill, but it really is about systems and about skills. And these things don't need to take more time. So it's about working smarter, not necessarily working harder and doing more of the same that confuses people. So that's basically, I think, where we want to focus on today. Today you've had certainly an all-star team of individuals present. And I want to really honor Drs. Davis, Delaha, Dr. Coleman. And my job, again, is to provide a bit of an overview and share some ideas, most importantly, that we're in this together. And so I want to thank you all so much for this time. I want to thank Merck for their kind invitation and for their support of this work. You know, I don't do any work at all in clinical trials, meds, anything related to pharma whatsoever. And Merck has supported lectures like this and cross-cultural care, which is work I do, as well as health literacy. So I'm really thankful for the work that they have done. It's always a pleasure to be in Crimson Tide land. Although I understand you let an LSU Tiger start your day off. Is that right? Wow, that's impressive, so I don't feel so bad. It's beautifully warm here. When I go back to Massachusetts on Saturday, it's supposed to be about -10, so I might just hang around for a little bit. But again, thank you for your time. So let me tell you a little about what I do, why I do it, and then I'm going to jump into the couple slides I have here to share with you. So I'm a practicing internist. I spend around 30% of my time practicing primary care internal medicine at Massachusetts General Hospital. Been there since about 2001. I direct efforts in our hospital in the area of multicultural education, which is in fact very, very well linked to health literacy. Basically what we're focused on is educating our doctors, nurses, and frontline staff to communicate effectively with anyone from anywhere at any time in an effective and efficient and performance-driven way. We call it multicultural education because we focus not just on different cultural backgrounds, but really understand that the healthcare culture is quite different than the patient culture. And we, in this world, learn to speak in a completely different language that is often challenging for us then to dial back and find common ground with patients. So we invest a lot of time and efforts in my role there on trying to give people the capacity to do a better job and actually try to track our patient experience in that regard. I also run a place called the Disparity Solution Center where we work with organizations across the country focusing on improving quality and achieving equity, improving care for vulnerable populations. So this is work that I live, eat, and breathe and care deeply about. I'm originally from New York City. I actually grew up in a bilingual, bicultural home. And one of my first experiences with the healthcare system was when I was 7 years old and I was asked to serve as an interpreter for my grandmother who didn't speak English so well back in the early 70s. I often talk about that experience because it was so formative to me and still shapes a lot of what I do as I think about that experience and kind of how that went. You know, we still see children as interpreters for their families, unfortunately, around the country. We did a survey of doctors just about a couple of years ago, probably about 5, 6 years ago, and we asked doctors in their last year of training, have they ever used a child under the age of 12 as an interpreter? In fact, 1 in 3 had used a child under the age of 12 as an interpreter. So although my experience takes us back to the early 70s, clearly we still see that happening. And so, you know, I remember that experience very well because, you know, your value goes up in the family, by the way, when you get asked to do this. You know, it was a summer day. My mother comes over and says, you're going to go with Abuela, with your grandmother, to the doctor today. and just come over here, sit down, we're going to tell you what to do, because everybody was working, they couldn't do it. And I will say that your value goes up, and if you're crafty, like I was a little crafty, I negotiated some stuff, right? So I said, well, if I do a good job, can I get this, that? And so we worked some stuff out. And then they gave me an orientation, right? They basically said, whatever grandma says, just say it to the doctor. Whatever the doctor says, say it to grandma. And then you have any questions, just raise your hand like a timeout. So it sounded really clear and easy, and off we went to the doctor's office. And I remember going in, and she'd seen this doctor for a while, and despite the language barrier, there was a lot of love in the room, which stuck with me because he was able to demonstrate caring in ways that didn't necessarily have to be verbal, good eye contact and the like. And so there was a lot of caring in the room that was demonstrated despite the language barrier. And so he began asking her questions, just like we do all the time. Say, Señora, how are you doing today? And she'd say, bien, doctor, todo bien. And then he'd say, okay, you taking your medicines? She'd say, sí, doctor, ajá, muy bien. And then he'd ask her, you feeling well? Your blood pressure's a little high. I'm going to make this change. Ajá, doctor, sí. And so I'll tell you, about 5 minutes into that visit, I'm saying, sign me up to be an interpreter any day of the week, right? This is the easiest job going, because no matter what the doctor says, my grandmother's saying, yes, yes, yes. A lot of thumbs up, a lot of winking. I'm like, this is a piece of cake. So the visit was going to be done now. It's about a 30-minute visit. It's going to be done in like 10 minutes. And we get ready to walk out the office. And I look up to my grandmother, and she's happy. He's super happy. They hug. It's all good. They're leaving. And I say to my grandmother, how did it go? In Spanish, I say, ¿Cómo nos fue? Right? ¿Cómo te fue? And she says to me, me fue muy bien, which means it went very well. But then she says under her breath and kind of giggles, pero no sé lo que dijo el doctor y no lo voy a hacer. Which means I'm not sure what the doctor said, and I'm not sure if I'm going to do it anyway. I said, great. So let's look good. You were smiling a lot, winking. We see absolutely that individuals, because of health literacy challenges, don't get enough recommended preventive care, don't know when to seek medical care, use medications in different ways based on their understanding. They have difficulty understanding their health insurance, difficulty understanding a nutrition label, locating providers and services. So here we are in a time of accountability in healthcare where we want personal responsibility and we want patients to do more, yet they struggle with some of the most basic things, I think, that are important for them to be able to be active in their care process. Now, again, the evidence is clear. Health literacy affects understanding, affects health outcomes, whether it be people who have chronic conditions and have less knowledge on how to act on them, understand how they operate, understand what they should do to address them, whether it be individuals with low health literacy being more likely to skip preventive care, more likely to have avoidable hospitalizations, readmissions, more likely to report their health as poor. I mean, it should be pretty clear. I know I think you were going to have a session today on not blaming the patient as well. That's part of this discussion. So the issue is, and I'll mention this later, patients don't get a manual on how to interact with us. They don't get, clear instructions. And so it's important, again, to not say, well, these patients, but instead say, what can we all do? And it doesn't just have to be doctors or nurses. We're really moving towards team-based care. What can we do a little bit better every day to bridge some of this gap? Now, as we look towards expansion of health insurance and different strategies in different areas around health insurance, we understand that health insurance literacy poses yet another area of challenge. In a survey of insured Americans conducted in 2012, only 14% of consumers could understand 4 common health insurance terms, including deductible, copay, coinsurance, out-of-pocket maximum. I will say this last bullet here, only 11% could determine the cost of a 4-day hospital stay. I'm surprised at 11%. I thought it might be 0%, because I don't know, given the lack of price transparency, I don't know who could at all anticipate what a 4-day hospital visit costs. But anyway, the bottom line is that there is another level here of understanding your benefits. So a key lesson for us has been, giving somebody insurance does not meaningful access make. You can, give somebody great insurance, but if they don't know how to use it, it's a challenge. And I'll say that what we also see, just briefly in the health plan space, is a shift of risk and responsibility to the consumer, which I fully respect. But, I saw a patient about 2 weeks ago who's a fireman who has great insurance in Boston and suffered a real bad cut on his hand doing some yard work and cleaning some old stuff up. And he waited a week to see me because he had an annual appointment already scheduled and because his copay to go to the emergency room was $150. So here we're shifting risk and we're saying there's, we want to guide people's decision making, but this is going to be something we're going to need to work out too, because here we're putting our trust in his ability to understand the risks of that cut and the importance of being attended to earlier, and when is it appropriate to go to the emergency room versus not. This is part of the health literacy challenge that we're going to be facing, and it's going to especially impact vulnerable populations who have little to no experience navigating our healthcare system. A key message I'm sure you've heard today is that health literacy is a universal issue. Anyone can have health literacy challenges. There is no one type of patient. In fact, patients do a lot to confuse you and to not let you believe they don't understand you, like my grandmother with her yes, 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 or other people using different strategies, saying, you know, that writing's too small, or my family helps me with my medications. They will use different ways to kind of obscure that from you, dress up quite well, try to obscure that, because for them it's taboo, right? It doesn't feel well that they're not understanding. And so that's a challenge. And we've seen people that are incredibly educated in finance, in law, and other areas who still don't understand very well what are the causes of the common cold. And so we have to have those basic explanations and think about a creative way to address this with the most educated as well as those who are least educated. That being said, we do have what we will call some high-risk populations, populations who we need to think about perhaps a little bit more. And they include certainly the elderly, individuals who are at a low income level because there might be some assumption that perhaps they've had educational difficulties in their background. Obviously, individuals who you know haven't finished high school, individuals who are unemployed, individuals from racial ethnic minority groups, individuals for whom language is a barrier, recent immigrants, and there's been some research around Medicaid and the vulnerabilities associated with Medicaid. I want to highlight, this isn't about stereotyping people, right? So you don't want to have somebody come in and say, I bet you have health literacy challenges. But on the flip side, a lot of times we don't always collect this information as part of registration and stuff, so we don't have this profile in front of us. So we think about it, and we just need to walk that tightrope of saying, okay, well, you know, there might be some more high risk, but how can I use a universal strategy that can make sure that no matter who that individual is in front of us, we can bridge some of those communication gaps? This is what healthcare is trying to focus on now. We in the healthcare system also look for certain red flags, right? Like frequently missed appointments, loss to follow-up, difficulty following recommendations around medications, unable to name them, lack of follow-up with tests or referrals, incomplete or inaccurately completed forms. I look for this a lot. People have to sign a form when they come into my office. I'll often look, can they write? You know, is that something they can even do? There's a couple of questions we ask around depression and other things, and I look whether they're able to fill it out. That's a quick marker for me as well. And individuals who are the yes doctor patient who say yes, 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 and have very few questions, they either don't understand or they don't feel empowered. And either way, we need to do something to address those two issues. Now, what I want to share with you here in conclusion is you've heard, I think, a couple of different approaches, certainly a lot of different tools. You may have heard about this one. This is one that we are using in our practices at a statewide level in very, very efficient and effective ways. It's free and available. It comes from the Agency for Healthcare Research and Quality out of the Health and Human Services. It's basically a contract they did with the University of North Carolina and some researchers there who have done a lot of work on health literacy as well. And again, I want to say one more time, you've heard from some great experts who are doing great work, a lot of different models. There's no one model that's best. Pick a model and act on it, I guess, is the important thing. This is just another item to be thinking about. This is called the Universal Precautions Toolkit. And basically the idea here is we talk about universal precautions in healthcare around patient safety. Universal precautions being you need to wash your hands, you need to do certain things carefully to prevent infection. They've taken that term and now applied it to health literacy to say we need to take basic universal precautions around communication with anybody we speak to because we can't assume that they're going to understand. Does that make sense to folks? So that's the concept around universal precautions. And what this toolkit does very basically is it includes practice behaviors that support understanding, assumes everyone can have difficulty with health literacy. It contains tools and resources, and these tools can be adapted to organizational needs. So we're deploying these in different practices. It has a whole menu of activities in there, and I'm going to walk through a couple now, some of the principles that we're using. And I think it's nice because it's not about teaching onesie-twosie individual people, but it's a systems-based approach at addressing this challenge. And so, you know, this toolkit focuses on, number one, forming a team of people who are charged with assessing the practice, assessing the care delivery site. And I think this could be done for employers. This could be done at health plans. This could be done in a variety of different sectors. So this approach of forming a kind of a strategic team who could, a strike force, who could look at how are we doing around communication is very, very valuable. Increasing your understanding of this issue yourselves as professionals to get a better sense of what are the gaps and what might need to be done. Making an assessment of the communications that you have with individuals, whether it be written or spoken. Certainly raising awareness and trying some of these tools and building them into the workflow no matter where you are. And then trying them and figuring out what works. Now, assessing your environment is absolutely critical. Several tools to do that basically will say, hey, look at the materials you give to patients around preparing for a colonoscopy. Major issue, a lot of people show up, there's time booked up, and they haven't understood how to do the prep well. And so now, it's been unpleasant for the patient. The caregiver now, there's been a lost slot, and so there's inefficiencies. And it's because we communicate things that are, incredibly complex in incredibly complex ways. So part of this assessment can be done through look at some of your written materials, even just hearing, hey, how do you explain X or Y to a patient? Beginning to do an audit of those care delivery sites is very, very important. And then certainly creating a welcoming environment. So part of this is really saying, okay, we're committed to service and experience. We're going to think about ways in which we're going to address the forms and any written materials, address issues around language barriers, not overwhelming patients. So basically saying we are, if you will, a health literacy friendly environment. And I think that's what we're moving to. And the toolkit really talks about 5 particular areas, and as I walked in, I was hearing some of this discussion. Communicating clearly, confirming understanding, encouraging questions, this creating a welcoming environment, as I mentioned, and making it everybody's responsibility, because this is a team-based approach. Everybody is incredibly busy. There's no doubt. So this isn't about adding a big lump of work onto one person or 2 people. If this work is divided among a group of people and everybody could watch each other's backs and maybe do 1 or 2 things, the net will be progress. And I think, I'm an incrementalist, and so I think this will be a slow march and a journey, but certainly I think that's a very effective way to think about it. So, there's no doubt that individuals can't act on information they don't understand, and we communicate spoken, written, visual, behavior-wise. And I heard when I came in here too, the types of words we use, like dermatologist, eligible, hypertension, pulmonary, topical, there are easy ways to say all those things. But that becomes the language. If I were to do a presentation to you of how I share data with one of my colleagues about a patient, it might sound like this: 72-year-old female, past medical history of COPD, hypertension, diabetes, complicated by, we have our own script. And so it's hard to dial back from that script. And so we are actually in our practices keeping lists of easier way to say things as prompts for us. Oh, hey, I just found an easier way to say this word. It's almost like a silly game that you do, but boy, I'll tell you, it's incredibly valuable. And you will not realize, you get shocked. You're like, wow, I didn't think that annual was such a hard thing. But, every year or once a year is just an easier way to say it. And you'll find these words, and you're basically trying to change the language of these caregiving sites. Limiting content and slowing down. I'm really good at slowing down, by the way. That's right, yep. And I always say I'm going to slow down, too. So, and focusing on need to know and need to do, really. So I think, again, we are trained to say, I really want to have an informed patient in front of me. And that's important. And I want to give them all the details about the condition. At the end of the day, though, we've realized that that's more about treating ourselves than about giving the best to the patient. Because really, you need to get them at first, it's like teaspoons at a time, right? Focus on the need to know and need to do, and you could build around that, as opposed to 20 minutes explaining the pathophysiology of diabetes, where nothing sticks, and they leave and saying, well, I got this long explanation, but I'm not sure what I'm supposed to do tomorrow, right? That's completely ineffective. So breaking down complex information and repeating it, certainly. Visuals, we have a lot of healthcare providers who are using iPads, their phones, being creative, finding easy ways, anatomy on the iPad. Say, hey, let me just show you. Let me tell you about back pain, why it's not kidney pain, why there's muscles in the back. This pain here, really, there's only the gallbladders here, your liver's here, orienting people in a quick and easy way. Picture says 1,000 words. And I do believe there is going to be an evolution in health information technology where you're going to walk into a doctor's office, have a screen, be able to kind of do some stuff, and really educate patients in a much more effective way. Visuals are going to be incredibly important in that regard. And listening. Listening's not easy. It's not easy, especially today when, I need to enter about 22 components in the electronic medical record, right? And so I'm trying to have eye contact, good body language, and while I'm trying to do some stuff here, and that's a challenge. So the same way that we understand the importance of the electronic medical record, we're struggling with how to maintain eye contact and maintain that kind of body language of, I care about you. I'm not a transcriptionist. I care, and I want to listen to you. And so how do you balance that? And that's something I think we're working through, listening carefully. Written communication, as I've mentioned, real basic ways of assessing written materials and choosing to make them better in a variety of different ways. There's tools to do that, really targeting 6th grade level. Funny joke, as I was looking at the title of today's group, it's the Alabama Health Literacy Partnership Stakeholder Meeting, right? That's a whole lot of syllables, right? But you get to think that way, right? You start to say, wow, that's a mouthful. But I love it, by the way, right? I love it. But the notion is that your mind will always catch, sometimes even catch when that's a like you'll hear, oh, that's a mouthful. And that becomes your protector for your basic health literacy gut instinct, if you will. On content and text construction, we're doing a lot of work around, I mentioned limiting content in 6th grade level. You've covered this at all. This is all in the guidebook, and I think it's very, very helpful. But it's not, it's not rocket science, although I do want to share one important thing that I learned, in the sense of small things matter. Getting people to play back what they've understood is essential. I mentioned that, but not making, again, people feel like you're testing them. Like when you say, I want you, let me know what you understood. You want to normalize and say, because I told you a lot, and I confuse a lot of people. You kind of put it on you. Those are the types of things that we're teaching. But on this next slide, I want to highlight one quick point around encouraging questions, which I think is critical. I used to think, oh, I'm good at this. I say it a lot of times. You have any questions? Don't hesitate. Have any questions? Don't hesitate. Have any questions? Don't hesitate. And I'm saying, trying to create the space of saying it's good if you have questions. And then I learned the health literacy tool, which is not do you have any questions, which is often yes or no. It's a yes or no phenomena, right? But switching it. Simple switch in language, but it changes the dynamic. It's what questions do you have? Or we covered a lot. What do we need to go over again? The whole dynamic changes. It's like, I know you have questions and I'm ready to hear them. Not, do you have any? Because who doesn't have questions, right? And so those are the subtle things that I think even for people who are in this world, we're constantly picking up on new and easy ways of making this part of our new language, these tactical considerations. So I'll end by saying a couple things. My peers are very overwhelmed. Healthcare providers, nurses, nurse practitioners, all of us are overwhelmed with the amount we need to do in the time we have. There's a lot of frustration when we don't get the outcomes we want with our patients, when we know we have something that could help them and we can't quite get them there. Those are the most frustrating situations for us. And the sense is that issues around effective cross-cultural communication, clear communication, health literacy, I don't have time for that. But at the end of the day, what providers will realize is that, Einstein says doing the same thing over and over again is insanity. That's what we're saying. This doesn't need to take more time. I tell a story oftentimes of the way I used to offer the flu shot, right? I used to, patient come in, I'd spend about 7-8 minutes explaining the flu shot, and out of a 15-minute visit, and a person with multiple chronic conditions, and by minute 9 or 10, they look at me and they say, no, I don't want it. And now I got 5 minutes to cover everything else, right? So I was treating myself. And you do this over, and you do this over, and you do this over, and you're like, man, nobody wants a flu shot, And then I realized, you know what? I'm going to change this around. I'm going to say, I'd like to offer you the flu shot. But before I say another word, do you have any fears and concerns about it I should know about? Before minute 1, I'm starting a negotiation around fears and concerns, not at minute 10. That is an example of how this doesn't need to take more time. I would argue it can save a lot of time and can get us a lot better outcomes along the way. So I know that in this audience, there are individuals from healthcare delivery, health plans, employers, and the like. And the bottom line is this is all of our business because we could all do better here. I mean, reading a credit card statement isn't easy, right? I mean, there's a lot of things that are hard to read. Health literacy and issues of health literacy are high stakes. And I think if we could all do a little bit better, we can make progress. So there's work being done now with pharmacists in their role as caregivers and figuring out ways in which they can use plain language and teach back in some of the same tools as part of the team. There's new focus on what health plans can do, whether it be ensuring information and communications are at a basic level of health literacy, building partnerships, developing metrics and assessing results, training people in member services or nurse case managers to communicate in very basic ways. Health plans certainly play a role here. It's not just at the bedside or in the office where this is important. And then finally, employers need to play a role. You all are spending a lot of money on health insurance, no doubt. There are things that employers can do here in this space. whether it be workforce policies that increase and improve health information, ensuring information is in multiple languages in the low health literacy level. If you're running a campaign for your employees on getting the flu shot, again, making sure it's basic. Using your purchasing power with health plans to say, hey, what are you doing around this? Because my employees run the gamut of the very, very educated to perhaps those who are less educated. So how are you going to address the needs of all the covered lives that I'm now giving you? That purchasing power is important. And so employers, I think, could play a very, very large role here as well through a variety of different approaches. So what are some attributes of a health literate healthcare organization? Number one, leadership buy-in, right? Leadership needs to buy into the importance of this and be able to be progressive enough to connect the dots between communication, cost, quality, safety, and value. Number two, plans and building systems that allow us to do better work in this area, including the voice of the patient and the community in that process. So whether it be focus groups, key informant interviews, partnering with community-based organizations, I think that's an essential part of that work. Ensuring easy access, easy to use materials, and really focusing on some of these high-risk issues. I want to end here with a story. When I was in New York, I did my residency in New York, and when I was in New York about a year or so after my residency, I came into our practice one day and was going to see my patients and walked over to the front desk, and the clerk had a stack of charts. This was 1998, 9, 2000. Had a stack of charts for me. Those are my patients for my day. And she, hands me the charts. And the top chart, there's like a mark on it. And she says, oh, that first patient, that's a difficult patient. So you know how that made me feel, right? I just had my coffee. It's 8:45 in the morning. I'm trying to get my day off on the right foot here. And I'm like, so what do you mean? Oh, yeah, she's difficult. So the scarlet letter's on that chart. And I said, what do you mean she's difficult? That's why she always shows up really early. And I'm like, okay. So what time's her appointment? And she says, her appointment is at 1 o'clock. And I look at my watch, and I'm like, and it's 9 o'clock now. So you're right, she shows up very early. And I said, am I 9 here? She goes, yeah, you're 9, 9:15, 9:30, 9:45 are here. So now my blood pressure's gone up a couple points, too. And I want that chart to disappear, right? That's what you want to happen. You're like, you sure somebody else can't look after her, right? The difficult patient. I said, where is she? And she points her over, and she points. She says, she's right over there. And so, these stereotypes happen. I'm picturing this big, mean person, I want to be seen. I'm here early. It's this woman. She's about 4'9", sitting there. She's in her 70s, sitting there with little glasses, little gray hair and a bun, couldn't look less menacing or difficult or anything. Sitting there with a smile on her face, right? And so I said, okay, I'll try to get her in. And so I basically, go. I see my first patient, see my second, see my third, see my fourth, and I get a no-show. So I bring her in around 11:30, and she sits down, and I have this conversation, and she's absolutely lovely. And this conversation said, things are good. Okay, I want to do this. I'm going to be your new doctor now. So everything's great. And so I said, okay, nothing difficult there. So far, so good. So I walk out to the clerk, and she'd been in our practice for a while. And I walk out to the clerk, and I say, and I've been at the practice for about a year now. And I walk out to the clerk. She's been there for 30 years now, the clerk. So you get where I'm going. So I say, hey, why don't we just give her 9 o'clock? I'll see her first, And she goes, okay, Dr. Bencourt, we've never tried that one before, And I'm like, okay, I hear you. Just do me a solid and just give her, 9 o'clock appointment, and I'll see her first. And she goes, okay, done. 9 o'clock, we'll see you in 3 months. Fast forward 3 months. I walk into the practice. I walk in, and there she is sitting down, and I am like, I'm going to try hard to not pat myself on the back as I approach the clerk, right? So I'm, like humble. I go over and say, thanks so much for doing that. I appreciate it, so I'll see her first. Great. She goes, yeah, great. Ask the janitor who opened up the practice who was standing outside at 4 o'clock in the morning. And I said, what do you mean? She goes, yeah, ask him. I said, what is she talking about? He says, oh, that lady? She was outside. Forget it. She was out when I lit the cleaners. When the cleaners were coming out at 3:30, she was outside. So I'm like, all right. So I bring her in, and she's a Spanish-speaking woman, and so we're talking, and I say, Señora, So I just want to figure something out. So, you know, you had a 1 and you came at 9. I gave you a 9. I heard you came at 4. I can't back it up anymore. Like I can't, you know, I can't have you pitching a 10 outside. You can't sleep over here, right? You know? So then I get this real, like, this revelation that I'm going to ask a very sophisticated health literacy question. So I look at her and I say, why do you come so early, right? Basic. And she looks at me and she has this, you know, explains it to me. And I would say that before that, I was making these assumptions, right? Elderly, maybe she could only get a ride at certain times. Elderly, isolated, maybe she liked the company of the waiting room. You hear these crazy things, right? And so she explained it to me. And then the next visit, she brought me a photo to express what she had explained to me. And it was a photo of a community health center, back where she was from, 7 o'clock in the morning, 1 doctor, 1 nurse, about 100 people outside, people with their kids, food and the like. And that was her previous healthcare experience. She never banged on the table. She never said, I want to be seen early. She showed up early because that's what she was used to. People don't check their health beliefs, values, or behaviors at the state line or at the practice door. People don't get a manual on how to interact with us, yet we're very quick to put a scarlet letter on them. It doesn't take a lot to remove that scarlet letter by just asking a basic question. That's what we're talking about with health literacy. It just took one thing, one extra question to shed light on the situation. And the good news is that when I left New York City to move to Boston, she started only coming about 2 hours early. So we were closing the gap. I thank you all so much for your time and attention. I wish you the best of luck, and I look forward to following this initiative, and I hope I could help in any way. Thank you all.